Thank you. Good afternoon. Cataract blindness. Cataract is the leading cause of blindness in the world. There are 40 million blind people, and 51% of this blindness is due to cataract. This map shows that 90% of these people with visual impairment live in developing countries. 80% can be avoided or cured, and 65% are 50 years or older. There's no race exempted from cataracts, and it's accepted as part of aging. It has a heavy socioeconomic burden with loss of the income earner, the need for a caretaker. There's decreased status and loss of opportunities, decreased health care due to limited income. Surgical rates. This map shows the surgical rates, and the surgical rates are highest, of course, in the Americas, Europe, India, and Australia, but pretty low in other countries. There's no FDA-approved non-surgical treatment, and cataract surgery alone cannot solve this blindness problem. In Africa, in some countries, there are only 10 eye surgeons in the entire country. So we need alternative non-surgical treatments. What's the cause of cataracts? I'm just showing this illustration actually to introduce you to the way the clinicians can grade cataracts. And the first row here represent nuclear cataracts of different grades. As you see, there's an increase in density in the nucleus in these standards. And in the other forms of cataract, for precision subcapsular, we use the area to grade the progression, and in cortical the same way. But in the nuclear cataract, which is the most common type of cataract, we use increase in density. What's the cause of cataract? For nuclear cataract, which is the most common type, when you grind up a lens and try to find out what happened pathologically and biochemically, you find out that there's protein aggregation. There's lens protein damage leading to clumping of the lens proteins, causing light scattering. And the main causative factor is oxidative stress, which initially damaged the proteins. This is a list of risk factors: UV and cosmic rays, smoking, alcohol intake, hypertension, trauma, eye surgery, high myopia, posterior vitreous detachment, poor diet, aging, genetic predisposition, and obesity. This is just a two-dimensional map of all the proteins in the lens, and separated by charge and weight, molecular weight. So the main structural components are the crystallins. You have the alpha, beta, and the gamma crystallins. And this is to introduce you to a special protein, the alpha crystallin protein, which is the key in cataract pathogenesis, nuclear cataract. Recently, it's been found to be a molecular chaperone, and it prevents the other cataracts from further damage, other lens proteins from further damage, and it's essentially an anti-cataract protein. So the alpha crystallin is a large protein, and it has big holes, as in the representation here. When other lens proteins are damaged, the tips of the amino acids unravel, and when the tips unravel, they become sticky, and they stick to each other, forming large molecular weight aggregates, and this causes light scattering, which is the cataract formation. So what the alpha crystallin does, it binds the tips that are unraveling and prevents the proteins from sticking to each other, essentially preventing them from developing cataract. So we wanted to find a clinical way to detect cataract so we could study this pathogenesis in vivo. And we found a a good method using dynamic light scattering. We worked with NASA, and why was NASA interested in helping us? It's because there's no, when you go on space travel, there's no protection from cosmic rays, and cosmic rays cause cataracts. So NASA needed help in finding countermeasures. Otherwise, when you develop blindness in outer space, there's no surgery there. So if you become blind, it's a one-way trip. So we collaborated with a physicist, Dr. Rafat Ansari, who was using a probe to study protein crystallization. And so we developed a device which does a 5-second sampling of the Brownian movement of particles in the lens nucleus, and using a low-power helium neon beam. And this is detected by the device, and time autocorrelation function is obtained, which we then convert into a particle size distribution curve. With the help of lab collaborators, we determined that the first peak in this particle size distribution is the alpha crystalline. So we tested it in various animal models, and we found out that it can detect lens protein changes before standard slit lamp and other photographic and lens imaging methods would detect these early changes. So we did a large cross-sectional study at the NEI on 380 eyes, and we used the AREDS clinical grading for clinical grading of the lens opacities, and we derived a main outcome measure from device which we call Alpha Crystallin Index. It's essentially the first peak divided by the sum of the first and second peaks. So it represents the amount of alpha crystalline in the lens. We found that there is a decrease in the amount of alpha crystallines with increase in opacity. So as the cataract progresses, there's also a decrease in alpha crystallines. And when we looked at all the patients, all the volunteers with no cataract, we also found out that with aging, there's a decrease in alpha crystalline in the lens nucleus. And in all patients who had advanced nuclear cataract, there were no alpha crystallines. So in summary, the DLS detects the loss of alpha crystalline proteins in nuclear cataract formation and with aging. And this is in patients. It also detects, it detects these early pre-cataractous lens changes, which could serve as an early alarm system for oxidative damage. So it's also useful as an outcome variable in clinical studies, in future clinical studies of the ocular lens. For example, in anti-cataract drug trials. So a measure of remaining alpha crystalline in the lens reflects the level of protective reserve, similar to a creatinine clearance reflecting renal reserve. Two recent cross-sectional DLS studies confirmed our results. One was done at the Wilmer Institute, and the other one recently in the University of Tokyo. So we wanted to do the rational second, logical second step, which is do a longitudinal study studying the same eyes over time. And this is an example of a patient who developed cataract after 11 months, and the so the alpha crystalline peak disappeared when the cataract appeared. So we did a large longitudinal study at the Wilmer Eye Institute. We studied 66 eyes from 45 patients, ages 30 to 79, for a mean of 19 months, so from 6 to 36 months, who underwent eye exams every 6 months using the DLS, Pentacam Scheimpflug, and clinical grading. So we did this test every 6 months. And we divided the patients into three groups. The groups that had the highest, so in tertiles, the group that had the highest alpha crystallins in the lens, the group that had the lowest, and the group that's in between. So as you notice, the ones that had the lowest alpha crystalline also were the oldest, and the group that had the lowest alpha crystalline also had the most advanced lens opacity, which we predicted from the first study, from the cross-sectional study. We expected that. So when we looked at the nuclear cataract progression based on the initial alpha crystallin index, we can see here that those patients or those eyes that started with the lowest amount of alpha crystallins had the fastest progression of the cataract, whereas those that had the highest alpha crystallins had the slowest progression or no progression at all. And this just shows the decrease of the alpha crystallin index in every age group. So all the age groups by decade had a consistent decrease in alpha crystalline over the period of follow-up. Again, we predicted this based on the cross-sectional study. We know there was an age-related decrease. And when we looked at the slope, meaning if the alpha crystalline decreased over time, so in this group, there was a significant decrease over time. The cataract progressed rapidly also, whereas those where the alpha crystalline did not change, or there were a few that the alpha crystalline, as we measured it, increased. There was very slow progression or no progression at all. So in summary, the DLS detects the loss of alpha crystallins as the cataract progresses over time. And then the subjects with the low baseline ACI and decreasing alpha crystallins develop cataracts faster. And then those subjects with the high baseline and stable alpha crystallins in the lens did not develop cataracts or had slower progression. So alpha crystalline measurements may be a useful cataract predictor or biomarker for nuclear cataract development. I just want to mention that since the main pathology in the lens is is caused by oxidative stress damage, we are proposing the ACI as a biomarker for systemic oxidative stress damage because these patients are exposed systemically to the same stresses as in the eye, whereas the eye is very accessible and the test is non-invasive and very convenient to do. So oxidative stress can be caused by radiation, hypoxia, noise, exercise, or even dust. And all this give rise to reactive oxygen species that damage the cells and molecules. So they cause anemia, muscle fatigue, cancer, neurodegenerative disorders, cardiovascular and respiratory disorders, as well as we know, cataract and corneal disorders. So it's also possible that the ACI may be a useful biomarker for aging in general. And I wanted to mention that we do have potential anti-cataract agents. Unfortunately, FDA have not approved any of them, and there have been very few clinical trials of them. But the last one, I just like to mention the last one is, since we know that alpha crystallines decrease when cataracts develop, and as long as you have your reserve of alpha crystallines, you can protect yourself from cataract formation. The question arises, how can we replace the alpha crystallines if we lose them? So there are several labs that are studying how to introduce not necessarily alpha crystalline, because the alpha crystalline protein is large and you cannot use eye drops to get into the eye. But they're studying mini chaperone peptides that can act as as chaperones, but can be introduced into the eye. Right now, they're injecting it intravitreally, and which has gained acceptance because of the use of vitreous injections for age-related macular degeneration. So I guess since we now understand better the factors that cause cataracts, we have advanced means to document and study the earliest changes leading to blinding cataract and to test the drugs. We have we have the potential anti-cataract drugs to help delay or stop progression. Then we need to pursue this cure for blinding cataracts by non-surgical means. Thank you very much.
Thank you, Dr. Datiles. Does anybody have a question for Dr. Datiles?
Yeah. Dr. Mitra.
Here you go.
Hi, there's numerous papers on the progression of cataracts following trabeculectomy,
Yes.
range from 5 to 50%.
Yes.
How does that fit into your model of progression?
Well, the work by David Beebe, he's been working on this model, ties up really nicely. One of his findings is that when you do a vitrectomy, there's increased oxygen oxygen levels in the vitreous from the retinal vasculature, and so with this increased oxygen in the posterior in the vitreous chamber, then there's increased oxidation in the lens through the posterior capsule.
By the way, I maybe I said I meant to say trabeculectomy, not.
Well, trabeculectomy, any surgery in the eye, actually, especially trabeculectomy, can short-circuit the flow of nutrients into the lens, and when you do that, then you're depriving the lens of most of its normal nutrition, and also you're decreasing the defense in the lens, and so you're setting the lens up for more damage from oxidative stress.
Okay, thanks.
Anybody else?
There's a question right here.
Okay. Here you go, sir.
Thank you. Very nice talk. I have a question about you're trying to correlate the alpha crystalline loss with the formation of the cataract. And do you have a mechanism of how alpha crystalline is degraded based on the age?
Well, the alpha crystallins eventually join the group that becomes high molecular weight. When it becomes full, it can no longer bind. It becomes one of them. Then it becomes part of the second peak, which is the high molecular weight aggregate peak.
Okay. So my next question is, you showed that certain regions in the world have high, like the North America, India, and Australia, high proportion of cataracts compared to the, the other, the Europe and so forth. So is there a dietary or genetic variations about alpha crystalline degradation? There's a link between those or not, or what is the reason?
I guess if we go back to the maps, there is we did another study actually. We did a study of young normals. I don't know if this is the map you mentioned, yes, or this other one. But we did we studied 50 eyes of young normals, and we found out that there was a big spread of the amount of alpha crystallins they had. We thought they would all have very high alpha crystallins, but no. So we believe now that you're born with X amount of alpha crystalline. Some of us are born with less, and some with more. So those born with less alpha crystallines are set up to get the cataract sooner. Whereas those with lots of them, that's why we see patients who are 90 years old and the crystal clear lenses. So they probably have good genes that they have lots of alpha crystallins, lots of protein to protect them.
So do you think there is a genetic link between the formation of the cataract? Is there a gene known to form the cataract?
Well, one member of our team, Dr. Hedgmanchek, has been checking on that, and there's no direct link, but there are a few genes that have been identified to be associated with cataract formation, but it's not a direct link. So there have been studies on twins, and I guess to compare genetic versus environmental effects, and there is a very strong genetic factor. The calculations are almost 50% genetic based compared to environmental.
So sooner or later, probably the gene will be, identified. Probably.
Yes. There's I guess he's studying not only families but thousands and thousands of age-related cataract to find out which gene is involved in age-related cataract.
Yeah. Thank you.
There's a question in the back.
You mentioned the use of intravitreal chaperone proteins to prevent cataracts. Has that ever been done in an animal model? Is there any evidence that works, or is it theoretic?
Well, interestingly, there'll be a talk later, I think tomorrow, about alpha crystallins in the retina, because people are finding now that alpha crystallins also is involved in age-related macular degeneration and protecting the retina. And so these studies giving intravitreal injections are actually aimed to prevent age-related macular degeneration. So we're piggybacking on them to look at the lens. But actually, it's amazing that the alpha crystallins are also molecular chaperones in the retina. So they're doing these experiments in animals in vivo, but mainly looking at the retina. So we've actually encouraged them to look at the lens also.
So we don't have the results yet, but
No.
you're okay.
No, it's a group from the East Coast. No, but from the West Coast. Sorry. Yeah.
I understand that aquasima provides nutrient to those. Then is that composition is different in cataract and normal aquasima composition?
Can you please repeat?
Under cataract, aqueous humor and normal has been compared or not? Aqueous humor nutrients.
Well, see, it's not that simple. It depends what stage of cataract, because a lot of people have tried to look at it during cataract surgery, but remember, it's already advanced and it has to be removed. So by that time, the lens capsule is very leaky, and so you see a lot of proteins in the aqueous humor from the lens. But of course, if you want to do it early, how can you do that? You have to subject a normal patient into surgery, and nobody really, it's unethical actually. So nobody's done it on patients.
Okay, thank you.
Is that it?
Thank you, Dr. Datiles.
Thank you.